Perfect. Okay. So I have no disclosures. And this very first family picture is a picture of my late parents as a reminder for me to sort of, on behalf of the Sue family, to sort of thank the Schulich Heart Center and to the members of the Division of Cardiology for the exemplary care of my father as he, over the last 20 years, he passed about 3 years ago from non-cardiac cause at the age of 90. And a big shout out to Cam Joyner, who was his cardiologist for many years. My mother also received her care during her last days in Sunnybrook. So I have a very close affinity and a close affection for Sunnybrook and the cardiology groups here, colleagues and friends. Now, you might ask, why is a older male physician talking about pregnancy and heart disease? And I'm not exactly the typical phenotype to talk about this topic. And how I got into this field was strictly serendipity. As I was finishing my training at Mass General many years ago, almost 3 decades now, I knew I was going back to Toronto, and I heard stories of very competitive and very sort of aggressive place to be. Actually, nothing compared to Mass General, by the way. And I said, you know what, I better have some skills. And I didn't know anything about statistics. I was a good fellow. I wrote 10 papers with my supervisors, but it was sort of see one, do one approach. And so I enrolled in the summer clinical effectiveness program, the summer course that turned out into a master's a few years later. That was run by Dr. Goldman of the non-cardiac risk prediction fame, Dr. Frank Cook, who was actually the person who ran the course. And I needed a topic for my clinical project. And not being particularly original, I was going to look at non-cardiac predictors of events for adult congenital heart disease, which is my other area of interest. Well, 20-year-old with tetralogy flows do not get AAAs, and they don't get hot gallbladders. So that was a no-go. Dr. Kara Mangione, who is a junior faculty, I think she's now the chair of general internal medicine at UCLA, said to me, Sammy, why don't you look at pregnancy? Women get pregnant. So that's how I got the idea. It wasn't mine. I have to give her credit. So with that, I went with it. I came to Toronto, and I was a clinician teacher. I was hired to read echoes, to look after patients, to teach. No one told me that I couldn't do research. That wasn't my place. I should leave research to the real scientists. So I started writing grants, and I was in the place where Dr. Gary Webb, who was the head of the Toronto Congenital Cardiac Center, which when he was a centralized care, introduced me to the head of the special pregnancy unit, Matthew Sermer, and to my future colleague, Jack Coleman, who's looking after pregnant women at Mount Sinai and in Toronto General Hospital. So right place, right time. And at that point, there's a lot of gaps in the knowledge base, and I was actually one of the only few clinically trained cardiologists in the city. At one point, I was the only. And then our team grew with my 2 original sort of co-applicants. We got an MRC grant, and then following a PSI grant. Dr. Silverzais joined us after she finished training. She went to Boston for a while, came back, and then ultimately she took over the program when I moved to London. And she's front and center for a special reason, because she has taken this program to a much higher level than I could have achieved. So it's always important when you recruit people to recruit people who are a lot smarter and have more vision than you have. And she's recently was awarded the Miles Nader Chair in pregnancy and heart disease, which is a big deal because now the program has credibility, has an endowed chair attached to it. And she's also the new editor-in-chief for one of the new JACC journals. So going places. And Dr. Jasmine Graywell, who when she completed training at UHN and also at Mayo, went to Vancouver and set up the pregnancy and heart disease clinic, and she's doing very well. Dr. Rachel Wall joined us from Hospital with Sick Children and also from Boston Children with her expertise in cardiac MRI and pediatric cardiology. And in London, I've been joined by Dr. Sarah Blissett, who finished 2 fellowships, one in ACHD and obstetric, cardiac obstetrics, and also in multimodality imaging. And supported by research coordinators. So these are people without whom I wouldn't be able to share the data that I will share with you in the next few minutes. Along the way, our national study was supported by members of the Canadian Adult Congenital Heart Work, which was chaired by Dr. Webb. This is our team picture in 2001 when our CarPreg study grew up. And Dr. Salim Youssef, sir, took me under his wings when I was still basically a tadpole in this business and taught me how to conduct multi-center studies. Once Friday afternoon, he sat myself and Matthew Surmer down in his office on Friday and opened the books to the HOPE trial and say, this is what you need to do. So a lot of people to thank, without whom this team would not be able to achieve anything of what I'm going to present to you today. So the learning objectives are before you, basically, how do you look after these women with heart disease? Let's start with a case, typical scenario that most of you will see or will see somewhere in your practice. Young women with severe aortic stenosis, asymptomatic, and she may be coming to you and say, you know, I want to get pregnant. They say, I need to talk to you, or I am pregnant, come look after me. What do you do? What sort of questions do you need to ask? What do you have to put down in your consultation letter? Well, I'm a simple guy. I like to keep things reasonably straightforward, mainly because my memory is never the greatest. And I said, I always say, let's talk about 5 things. What's the risk of the mom? What's the risk of the baby? What's the recurrence risk if the patients have congenital heart disease or the sibling has a congenital heart defect? What are you going to recommend at the time of the antepartum period, before labor and delivery, or before pregnancy, if you're lucky enough to be able to have this conversation? And what do you do at the time of labor and delivery and in the postpartum period? So I'm going to take you through these sort of 5 series. And so you say, well, what's the big concern? You know, women get pregnant all the time, and you know, we're through the dark ages, and labor and delivery is relatively complication-free, but not for patients with heart disease. In Canada, the maternal mortality rate has gone from 5 per 100,000 in general to 12 in 100,000. And same thing, higher than UK, but not as high as the USA. Not all from heart disease, but really reflecting the changes in the demographics. Our mothers are getting older. Many of them have acquired coronary risk factors, diabetes, hypertension, obesity. And cardiovascular disorders are the leading cause of maternal mortality in the developed world. So cardiovascular disease or Cardio-Obstetrics hit mainstream. You can see that these are some of the recent guidelines that's been published. Now, the American College of Obstetrics and Gynecology have recognized that cardiovascular disorders or complications in pregnancy is a big deal. It's a high impact, a critical event. And so once the Americans practitioners have gotten into it, it becomes mainstream, which is good because up to this point it's a niche item. Tucked away under congenital heart disease or under valve disease. And if you read Jack, in the last year, there's been a series of 5 very detailed articles, very prescriptive articles on how to look after these women. Now, my caution is that it's really reflective of the USA health care environment and insurance coverage. And we in Canada have always also are publishing a clinical practice update commissioned by the CCS. So that was coming out in print shortly. And this coming weekend is the annual Cardio-Obstetrics Symposium, which 2 days talk about everything you want to know about looking after pregnant women with heart disease. But afraid to ask, perhaps. So what is this Cardio-Obstetrics issue? It's really a rebranding of the pregnancy and heart disease program, but with the following detail. It emphasizes a team-based effort with the cardiologist and the high-risk obstetrician being 2 members, but with other members being involved to really provide a holistic approach to care. It not only talks about what happens during pregnancy, but also what you do at preconception, and it focuses on not only lesions, but cardiovascular risks in general. This slide is a slide which, early in my career when I had no data, I could spend 45 minutes to talk about. Now I spend like 15 seconds. This is basically a plot over your gestational age over time, from conception to delivery, of the changes on the cardiovascular hemodynamics over time. cardiac output is starts to rise during the first trimester, peaks during the third trimester, and maintains that rate until delivery. In the beginning of pregnancy is mostly brought about by increase in stroke volume from salt and water retention and increase in red cell mass. And later in pregnancy is maintained by increase in heart rate. This tremendous increase in cardiac output does have to normalize. And after the baby is delivered, the uterus is no longer full, so it doesn't compress the intrauterine cava. And there's also redistribution of fluids in the first part of the week. So these patients are with structural heart disease are predisposed to what we call redistribution pulmonary edema. Remember that from our general medicine that pregnancy is a pro-pulmonic state, is pro-arrhythmic. The changes in renal function, increase in GFR, changes in drug metabolism and protein binding, and changes in cholesterol metabolism. So a lot of things happen. So that's why they call pregnancy sort of a stress test for life. What type of complications do we usually see in pregnant women with heart disease? Well, in the CARBREAK 2 study, which is our consecutive series of patients looked after at Toronto and also Vancouver from 1994 until 2014, sustained arrhythmia and heart failure number 1 and number 2. So most of the time, these are non-fatal events, thank goodness. Cardiac arrest, cardiac death are relatively rare. Still many orders of magnitude higher than the general population. When you look at these two most common type of complications, the peaks are different. Pulmonary edema, usually highest incidence during the third trimester and the first postpartum weeks, reflective of the fluid shifts and the hemodynamic changes in pregnancy. Arrhythmia, on the other hand, can occur almost any time, reflecting the reflection of cardiac stretch and also changes the proarrhythmic effects of hormonal changes such as progesterone. Other groups have shown similar features, findings such as the ROPAC study, which is an internet-based international registry, again, peaking of heart failure incidence during the first trimester and in the first postpartum week. And we have shown 2 separate publications that if a mother has a complication in the antepartum period, either cardiac events such as heart failure or a recurrence of a arrhythmia, they have a 2-fold chance of having preterm labor or baby with growth restriction. In other words, remember that the placenta does not auto-regulate. So whatever blood pressure it sees from the mother is the blood pressure that the baby sees. Now, going back to our cases, what's the risk of this in general of this young women with severe aortic stenosis during pregnancy? Probably in this age, 2%. At the beginning of my career, as one article says, an 11% mortality rate, which is pretty frightening. 9% pulmonary edema, and a small chance of having stillbirth and neonatal death. Remember, the chance of stillbirth and neonatal death is less than 1 in 100 in general series. So this is still much higher. If you have moderate aortic stenosis, the risk to the baby and to the mother is much lower. Now, this is a compendium of all the independent predictors of maternal cardiac complications that we put together. Dr. Silvesaz and I are the co-authors of the pregnancy chapter in Bromwell's heart disease that's coming up. So we started look at all the literature, and basically they're functional predictors, lesions predictors, and process of care predictors. So a lot to remember, and also obesity. So one way to help you organize your thoughts about risk is to look at the risk score. So many years ago, we published the CARBREAK risk score, which basically says, if you ask the question based on history, physical exam, and echocardiogram, you can put people into so-called low, intermediate, and high risk buckets. And later on, we expand this with the CARBREAK 2 risk score, where we have a weighted score, where we include other things like pulmonary hypertension, mechanical valve, and process of care, like the fact that you didn't present until past 20 weeks to a referral center. Put people again into a broader number of categories, but still low being 0 to 1, intermediate being 2 to 3, 4 and greater than 4 being the highest risk group. And this CARBREAK 2 outperformed CARBREAK risk score, the original one, and other current risk classification system in the Canadian cohort. The WHO is heavily promoted and marketed, and I use the word promoted because it's promoted because many of the people writing the guidelines like it. It's not necessarily a better classification system. However, it is simplistic because you can look at the lesion and sort of put people into various risk buckets. The risk score, the risk estimates are arbitrary. You can see in the highest risk group, the so-called WHO 4, 40 to 100% is a big confidence interval. So when we talk about risk assessment in general, is that's more than lesion severity. You have to put general risk factors, patient-specific factors, process of care. And we've recently shown that even when you sort of adjust for all of these, such as using carpet 2, if the patient is obese, BMI greater than 30, it has incremental risk as far as cardiovascular risk in the mother, also preterm chance of having a preterm birth, and also a chance of having a growth-restricted baby. But interestingly, the ones with underweight mothers have the highest chance of having a growth-restricted baby. Now, we used to say that patients with regurgitant lesions are usually well tolerated because the systemic vascular resistance drops, and so does pulmonary vascular resistance. So you say, well, if you have severe aortic regurgitation, you do a lot better than severe aortic stenosis. Not necessarily true. We've looked at a group of patients from our Vancouver and Toronto cohort, and after we exclude the patients with significant stenosis, those with moderate or severe valve regurgitation, if they have multi-valve regurgitation, in other words, more than one valve, they have the highest chance of having cardiovascular risk, which makes sense from a sort of clinician point of view. And all of them have a higher neonatal risk than the general population. Your general neonatal event rate in a woman with heart disease is about 18 to 20%. Now, when you look at it further and you look at the subset of patients with mitral, tricuspid, or multi-valve regurgitation, if they have a high-risk feature, such as a prior cardiac event, ventricle that's depressed, or pulmonary hypertension, any one of them, they have a 1 in 3 chance of getting into trouble. If they don't, they have a 6% chance. Again, it's the combination of lesion severity and functional consideration that determines your overall risk. It's a lot to think through if you don't work with this area every day. So we sort of provide this sort of algorithm to sort of help the general clinician to sort of put everything together. We basically say, look at the patient's lesion. If she has a high-risk cardiac lesion, for example, a mechanical valve, symptomatic mitral stenosis or aortic stenosis, if she has some sort of significant ventricular systolic dysfunction, or some sort of arterial issues, or isomangus, pulmonary hypertension, this lady goes into the high-risk bucket. You don't have to do any risk scores. And if you're not, then you can use the carpet 2 risk score and factor in your lesion and patient consideration. You know, is the patient compliant? Is the patient live 200 kilometers away? Can the patient afford to travel to downtown Toronto or downtown London and pay for the parking and have somebody give her a ride there to take her back and forth, that type of stuff, that increase her risk or decrease her risk. Then you can put people further into low, intermediate risk, and you can still put people in the high risk, depending on your consideration. So this is one way of looking at things where you put everything together. Now you say, well, I don't like this. I'll just go with WHO. I would caution you that you probably need to also apply the cardiac 1 score, because within each WHO class, even in the highest risk class, not all of them are the same. So you apply the cardiac score 0 versus 1 versus more than 1 risk factor. You prefer to classify patients within each WHO class. And those who are unclassified are not necessarily at low risk. This very busy slide, it basically shows you that there's a lot of similarity between the predictors of obstetric and fetal neonatal complications, and that predicts cardiac complications. The correlation is not that tight, so there's been multiple attempts to see if the same prediction rule or classification system can predict both maternal cardiac and maternal non-cardiac complications, and the accuracy has not been great. So I'll give you from general risk. I just want to draw your attention of the 5 lesions that give me chest pain. These are the patients that, if you see them, they are straight referred to the Cardio-Obstetrics Center. Don't even think twice. These are the patients with mechanical prosthesis, pulmonary hypertension, acute coronary syndrome during pregnancy, the aortopathies, and the peripartners where they don't recover the ejection fraction. Very busy slide showing a summary of the outcomes of various anticoagulation regimens with mechanical prosthesis in pregnant women. Remember that no regimen is equally protective for mom and baby. So you're making a value judgment, and it's a shared decision making with the parents. And also you need to have the infrastructure, the commitment to follow these patients. If you want to follow low molecular heparin, which is the highest field safety, you need to have a hematologist that's going to be at your side, that's willing to do anti-10A levels. Weight-based dosing of low molecular heparin is not sufficient and is actually hazardous. If you go with straight vitamin K, it's the part of the safest for the mother with the lowest live birth rate. We don't use low fractional heparin, especially sub-Q, at all these days in North America. It simply doesn't work very well, especially in the third trimester when you have this sort of relative heparin resistance. This is a very basic slide showing the algorithm. If you have a mechanical valve on the left side that you suspect to have a thrombus, and the take-home points are outlined yellow. In most of these women, you need a transesophageal echo. A transthoracic just will not give you enough of a diagnostic accuracy, just like in a non-pregnant woman or non-pregnant patient. And just like in a non-pregnant patient, once they decide that somebody needs an intervention, it's a big clot, there's mechanical obstruction, don't dawdle. Okay, either you're going to thrombolize or you take a patient to surgery. Don't say, well, we'll put her on a few days on heparin and hope for the best. It doesn't work. She will just die on you, okay? And we've learned the hard way that for aortic valve prosthesis, that a transesophageal echo may not be enough to exclude clot. So you need to have often a fluoro. Pulmonary hypertension used to be we used to quote like a 1/3 mortality for the mother, 1/3 mortality for the infant. It's probably better now with vasodilators and very careful therapy. But remember, these patients are at risk up to a month after delivery, partly because of incomplete diuresis and RV dysfunction. And most literature uses an echo parameter. As you know, it's not always 100%. And as you know, the diagnosis is based on cardiac catheterization and the mean arterial pressure. Dr. Diane Zawicki from Milwaukee probably has the personal best record, and she's reported like 170 pregnancies with no mortality, but she's never published her data, so we won't look at how she does her regimen. Look her up in Google, and she has a slide top from, I think, from 2018 that you might be helpful. Again, get your friends from Pulmonary Hypertension Service involved. This is not a one-person show. And bosantin and endorphin antagonists are teratogenic. Marfan syndrome, we follow during pregnancy with a serial echo. We use CT and MR if needed. Concern with radiation, and also GAD. We put everybody on empiric beta blockers, not supported by data. We try to reduce their heart rate by 20 beats per minute, but we keep the heart rate at least 60 or 70. You can't block them down to less than 60 like for post-MI patients. They need the higher heart rate than baseline to maintain the cardiac output for the baby. And in some cases with very big aortas, we say pregnancy is contraindicated. Remember, in Turner's, used to be not an issue, but now with IVF, a lot of Turners are getting pregnant. You always have to index the aortic size by the body surface area or by the aortic root height, because these women are short-statured. This is a algorithm of what to do if you run into aortic event during pregnancy. Our recommendation from our CCS clinical practice update, basically get them to a surgical center where you have maternal fetal medicine also, because they can help you define the probability of having viability versus non-viability. And then depending on what you need to do, it tells you the order that you do your intervention. If it's a type B dissection, you probably still need to get them to a referral center, because again, you need a sort of team approach to decide the best approach. Pregnancy is a risk factor for myocardial infarction because change in the lipid levels. Pregnancy is an inflammatory state. Pregnancy is associated with changes in all the arteries. And the case fatality rate for MI during pregnancy is about 5%. Remember, SCAD, or spontaneous coronary dissection, occurs up to almost 1/2 of patients. So lytic therapy is not recommended. Most of these MIs, as you know, happen in the third trimester of postpartum period. Most of them are STEMIs, and most of them are anterior. And the typical Jacqueline Saul classification type 1 is often not present, not apparent. So you may need OCT, or you may need other modalities to make the diagnosis. And we usually advise a conservative approach unless there's high-risk features. Remember that if you cath a pregnant woman, even without SCAD, there's about 3% chance of having iatrogenic dissection because it changes in the arteries. And the risk is thought to be a little higher with radial approach because the more tendency to deep seat the catheter in the left main. So you have to think about those when you're taking somebody to the cath lab. And there's also technical considerations about doing PCI in pregnant women. So instead of doing the distal stent first, you might do the proximal stent first so that to prevent retrograde extension of the flap. And irrespective of SCAD, even if you have somebody who bypassed surgery or had previous myocardial infarction from atherosclerotic disease, there's about a 10% cardiac event rate during pregnancy. So these patients are high risk. And again, this is the algorithm for how to deal with acute coronary syndrome during pregnancy. Again, for STEMI and for the high risk non-STEMI, basically you talk about cathing early, whereas the other ones you might want to sit tight, and you depending on your clinical judgment. And again, get your cardiac obstetric team involved. Pericardial cardiomyopathy is a moving target. We spent at least 2 or 3 sessions on it, but the baseline prognostic hasn't really changed. So if you start with ejection fraction in the severe range, only a third of them will recover to a normal ejection fraction in 1 year. However, if it's in the moderate range, almost all of them will recover. Most of the time they present at less than 45% presentation. Beware of mild left ventricular dysfunction after surgery, after delivery that recover within days. That's probably not peripartum cardiomyopathy. And again, they can occur prior to the last antepartum month. And they're worse in outcomes in African Americans. And there's, like we say, there's a trial on bromocriptine that's just been funded for the NIH. So we'll know the answers soon. But right now, at this point in 2021, if you're in Canada, it's supportive therapy, diuretic, ACE inhibitor, MRA, postpartum. And if they don't recover at left ventricular ejection fraction, they should not undergo another pregnancy because that has a 20% mortality risk. However, even if they recover the ejection fraction, 20% of them will run into heart failure, and some of them, the ventricular systolic function may not recover. So as a general rule, my recommendation is that once you've got peripartum cardiomyopathy, you probably should not entertain a repeat pregnancy. Now, we now know that it's the pregnancy, after pregnancy is finished, the obstetricians have signed off at 6 weeks. Your job as a cardiologist or primary care provider is not done, because Dr. Ray has shown with Dr. Redemeyer and colleagues in ICS that if you have maternal fetal placental syndrome, such as abruptio placenta, preeclampsia, fetal death, things which are vascular in nature. Remember, the placenta is the largest vascular bed. Somehow it changes your vascular health, and the mothers are at risk for cardiovascular events during later in life, in the decades later on. In conjunction with Doug Lee and the ICS experts that I've now joined over the last year, we just put together this paper that was published earlier this year, where we took our Toronto cohort of pregnant women with heart disease that we looked after, import them in ICS, match them 2-to-1 to a comparison group of women without heart disease, that delivered in the same time period did all the very sophisticated adjustment and matching, and showed that in the heart disease group, a further ran into problems in the 2 decades. Remember, the mean age of these women were 28, so these are mean age of about 48. These are women in their 40s and 50s, in the prime of life, working, being parents, looking after elderly parents. So this is a very important health implication for these group of women. And what is this cardiac? What are these cardiac events? These are this composite outcome of death, heart failure, arrhythmia, atrial fibrillation, stroke, myocardial infarction. And importantly, we show that this cardiac risk score in the WHO risk classification can not only predict what happens during pregnancy, but they also can predict what happens long term. So so you can risk stratify somebody not only for complications during pregnancy, but the chance of having cardiovascular events decades later. We also show what we call the multiple hit hypothesis, that if you have heart disease, but you have no cardiac complications, you're higher likelihood of running into trouble compared to controls. But if you have heart disease and you have a cardiovascular or secondary events, you're even higher risk. In other words, there's now evidence that obstetric events somehow leads to a cascade of vascular abnormalities that increase cardiovascular events down the road. Now, in the last section, I would quickly talk about how to manage these patients as a first line. We see them whenever they refer, and again, in the third trimester, we should definitely do an echo and baseline. In some cases, we repeat the echo, and you increase the frequency of follow-up according to risk. The obstetricians have their own follow-up regime. Fetal echo at 18 to 20 weeks if they're at risk for recurrence of congenital heart disease. And we frequently will have these patient care conferences. And now with the virtual, it's a lot easier to sort of schedule these patient care conferences without people physically having to travel. And where to deliver is a combination, is determined by the risk level, how comfortable their caregivers are at the community hospital, and patient preference. We usually advise against home birth, underwater birth, definitely no. And most of the time, aside from very specific indications, we do not, we basically advise that they can have a vaginal delivery with regional anesthesia. And the only time most of these combinations are indication for cesarean section for cardiac reasons are for aortopathies or preterm labor in a mom who's fully anticoagulated, severe pulmonary hypertension, and in the hemodynamically unstable mother. But most of the time, vaginal delivery with regional anesthesia. And for patients with atrial shunt, we recommend a bubble trap to prevent paradoxical right to left shunting, especially during the strain. Postpartum, we usually recommend for those who are at risk of redistribution edema, diuretics, 20 to 40 milligrams of furosemide IV given one time within 4 hours, assuming there's no postpartum hemorrhage. And then we follow them either 6 weeks or 6 months. Refer the baby for pediatric assessment for congenital heart disease, because we are showing that the fetal echocardiography does not always pick up the minor congenital lesions. Contraception is a whole different area. It's something that there's actually a separate publication in that JACC series on contraception. But most times, be careful about the use of combined hormonal contraceptive in patients with serious heart disease. Now, going back to our patients with aortic stenosis, what to do? If she comes to you before pregnancy, when would you advise that she should look at getting her valve replaced before pregnancy? Well, if her ejection fraction is abnormal or she has an abnormal exercise test, that would be a indication for intervention. Remember, it's a shared decision-making about the choice of either biological, mechanical procedures, or Ross procedure. Not every person will be eligible for a Ross procedure, and decision on biological mechanical procedures will have implications on your risk assessment and your management during pregnancy. If the valve is not calcified, usually in a very young patient, you can get away with vapovotomy. It might buy you a year or two until you get through the pregnancy. And the patient runs into trouble. TAVR is a promising alternative. It's not standard care in some case reports. And we try to avoid cardiac bypass in these patients because it has up to a 30% fetal death rate. So just a very busy slide, but basically it shows the algorithm how to look after heart failure. Pulmonary edema during pregnancy usually respond to medical therapy because fortunately most pregnant women has a reserve ejection fraction. They're not likely going to go flat or will hypotensify you. But if they run into trouble, you need to get them to a center where you can have mechanical support. Arrhythmia is quite often non-sustained arrhythmia like PAC, PVCs, even non-sustained atrial tachycardia VT can be encountered in normal women. And the treatment for them is largely the same as for non-pregnant women. Adenosine, beta blockers, except Maternal, diltiazem, digoxin, electrocardioversion are all relatively safe. In the first trimester, you can use pretty well anything you want because there's no worry about teratogenicity. And this is a detailed table from our clinical practice update. And Dennis, I'm going to provide a preprint copy of this that you can distribute to the group because I think a lot of these tables are very busy and also have very detailed algorithms. It'll be very good for the cardiology fellows also. Talking about drugs which are considered safe, these are what we call the golden oldies, things like labetalol, methyldopa, digoxin, and the less common, and then the ones that you should try to stay away from, such as the direct oral anticoagulants, and those to avoid while breastfeeding. If you ever have the misfortune of having to run the cardiac arrest in a pregnant female, you have to remember past 20 weeks, always need to move the displace the uterus by manually to one side so you can have effective compression. You need to have an expert intubator involved, and to use epinephrine rather than vasopressin, and keep the IV infusion in the upper extremity. And after 1 or 2 rounds, after 2 rounds of meds and you're not getting ROS, you better get the baby out by emergency cesarean section at the scene, because that's the best chance of saving both the baby's life and also the mother's life. So our clinical practice update basically recommend that any women with cardiovascular disease should be risk stratified in a cardiac obstetric program, should be seen at cardiac obstetric program. Now you can say, well, these folks are building empires and increasing the billings and taking my patients. Well, we actually have some data to show that it actually makes a difference in their outcomes, because at the end of the day, you have to say, what is the value? What is the outcome divided by the resources? So in emerging countries, from the ROPEC data, there's actually a gradual reduction over time in the death for heart failure rate. And within our CARPREG 2, when we compare using a propensity adjusted comparison between 1984 to 2000, which is the pre-CARPREG era, where most of these patients were cared for either by myself or Dr. Coleman through our offices, versus a combined clinical approach where we have CARPREG risk stratification, there's a halving of the pulmonary edema rate. No change in the arrhythmia occurrence. So in summary, in this area of cardiac obstetrics and looking after pregnant women with cardiovascular conditions, it's a team sport. And remember that current recommendations are really based on expert extrapolation from observational studies of variable quality. There's no real sort of randomized clinical trials evidence to guide us. And so, it's a little softer ground. And when you apply these guidelines for these reasons, you need to be nuanced in how you adapt into your clinical situation, and do not take away your clinical judgment, and always be mindful of your local practice and resources. And I phrase my clinical advice so not to paint myself or my colleagues or my obstetrician providers into a corner, especially from a medical legal point of view. And do not hesitate to ask for advice. This is my email. Dr. Silverside kindly provided her email if you have any questions about referrals, about just a quick curbside. And the last slide is a plug for our upcoming virtual leadership program, which we're running for the 4th year. That's a hobby of mine, of teaching physicians how to work effectively within our health system. We did basically taking some of our MBA's curriculum and put them into little modules. So this one is coming up in October 21, 28. It is virtual. In the past, we've had 1/3 of our attendees has been from the GTA. And this time, you don't even have to drive down to 401, which is not always the most pleasant thing to experience. So I thank you for your attention, again, for your kind invitation. Look forward to your discussions and your questions. Thank you, Dennis.
Thanks a lot, Sam. Perhaps I'll ask you to maybe just unshare your slides. I'm going to go to, I promised that I will go to the resident group so that we can see them. I think they come to rounds all the time, and just would like them to kind of just, I think they have a question to ask.
Hi, Dr. Sue. My name is Mike. I'm one of the cardiology residents. On behalf of all the residents, thanks so much for your talk. It was excellent. I think like we focused a lot on patients with pre-existing cardiovascular disease. And this may not be your patient population, but an area I find interesting is patients who develop preeclampsia in pregnancy. We're seeing higher rates of cardiovascular events in the future. I wonder if you had any thoughts on this phenomenon. And again, it may not be the patient population you follow, but any thoughts on this phenomenon and kind of what sort of monitoring these patients should have in the long term?
Yes, it's not the typical cardiology practice that I see, but I see increasing amounts of them. And so I think the relationship between preeclampsia and future cardiovascular risk is what basically motivates our research work on cardiovascular outcomes during pregnancy, post-pregnancy. These patients really should be, once they have preeclampsia, as you know, the recent lipid guidelines, they need to be screened with lipids, number one. Number two is that they need follow-up on a serial level. These are not patients that you sort of say, well, I'll see you at 6 weeks, your blood pressure is normalized, because they probably need to have careful follow-up, at least for the primary care providers, at least annually, for risk factor modification. And if their blood pressure is still sort of, after coming off the medication, is still sort of borderline, they probably need to have ambulatory blood pressure monitoring. So these patients are emergent if you're looking to expand your practice, okay? These are a new area of patient population that will need follow-up. Does it need to be done by a cardiologist? Maybe not, but certainly by the primary care provider or general internist. And I think this is one of the niche that the folks that talk about cardiac obstetrics talking about as far as follow-up. So there may be I can foresee at some point in time when we have more people, where we have a dedicated postpartum or post-obstetric cardiology clinic that basically just look at secondary risk factor modification, just like we have for cardiac rehab, for example, like post-myocardial infarction. Same principle, but maybe more of a drawn-out affair. It's not only a 6 month, but going to be a more longitudinal affair. And there's also a area because people have shown that post-preeclampsia, if you look at them, if you do contrast echocardiography 8 or 10 years down the road, there are changes in remodeling. And there's some data that shows that if you do contrast echo and look at perfusion, there actually is abnormality in perfusion, not necessarily from epicardial disease, but actually from the microvasculature. So it's a growth area.
Thanks a lot. I know Eric has a question. Eric, you want to go ahead?
Sure. Thanks, Dennis. And Sam, thanks very much. Good to see you. And as always, great talk. My question's around training of young cardiologists to go into this area. Is there, I should know this, but I don't. Is there a diploma or an area of focused competence in obstetric or maternal medicine in cardiovascular?
Well, this area is such a niche area. It's sort of like congenital when I started out 30 years ago, is that you sort of, show up and see patients with somebody who's done this for a while, and you sort of spend some time and away you go. Most people have gone into the cardiac obstetric area usually through adult congenital heart disease, because 70% of patients with structural heart disease going through these North American centers have some sort of congenital heart disease. So if you're comfortable with things like Fontans and Mustards and and tetralogy follow, then it's an easier the learner curve is steep. But I think there are a number of statements from the American College of Cardiology, from the subcommittee, and also from the CCS. We've actually just published a short sort of op-ed about what we need to do. At this point, there's no certificate program, but I think at one center, Dr. Silverzais and I were talking about having some sort of joint program, because you need a large volume. Even at the so-called referral center, we don't have clinics every day. You might have clinic one day a week, and a busy clinic you might see 15, 20 patients. But in most centers, they might see 2 or 3 patients a week. So you need a very large center. It's a small area. So I think we're in the early stages, and it's sort of nice because it's
and you can,
yeah,
and you know the Toronto situation well enough, so you can perhaps understand our dilemma a bit, which is that the adult congenital, particularly the complex adult congenital, is all concentrated in one place downtown.
Right.
And yet we have a large obstetrics program at Sunnybrook. So, I feel like it's important for us, but we probably see very little and never will see large numbers of complex congenital, because that's downtown. So we're kind of in between in terms of the requirement for the expertise.
But I think that at the same time, with this virtual world, it opens up a whole series of possibility, right? Because it has forced us to, the new word is pivot, right? In 2020, to look at new way of delivering care, and that we don't necessarily need to be in the same room. That if you, for example, if you have good echocardiography, which you do at Sunnybrook, and you have clinicians who are experienced, which you do, then it could be more of a joint effort. Patient doesn't necessarily need to be physically going down to Mount Sinai, for example. Okay, not that I'm looking for business. I can even do it from London. So I think they're new model of care which will open up that. At the end of the day, as the Mayo Clinics used to say, the interest of the patient is your only interest, right? And what's the best care of the interest? And you try to not have the patient go one center to another and back and forth, that type of situation. Yeah.
Thanks a lot, Sam. I think my question is similar to Eric's. Every time, most of the complex patients do go to downtown, but there are patients that comes here. You have arrhythmia, you have chest pain, you have heart failure, cardiomyopathy, and I feel that we get called to the obstetrics units, and you're always struggling. You don't know what drugs to use, what's appropriate. They don't have enough telemetry, and I don't even know whether there's some core basic curriculum that you recommend for us. But because every time we get called to the obstetrics units, we really struggle, and I find that we don't know at least I don't know what to do when I get up there.
It's a niche area that many of us are not comfortable in. I get calls all the time. At one point, the case room at Mount Sinai, I used to have my home phone number. I would go out of town, land at the airport, call my wife, say I've arrived, and the first thing she goes, this case room is looking for you. But these days, I think with virtual and with a text and phone call, you can always get hold of somebody. I mean,
okay, we'll get your number after this.
The other thing is that I happy to share my cell phone number for your group if you just want a quick curbside. The other thing that I'm happy to just for the division, happy to share the preprint copy of our Braunwald heart disease. We basically put everything we think that a non-pregnancy cardiologist needs to know in that chapter, and it's updated until early this year. So everything you want to know. And then between that and the clinical practice update, it has all the different sort of what we call the key points. Yeah. So
thanks a lot, Sam. I think that's really generous of you. Yeah, I think sometimes it's knowledge and also somebody to hold your hands because there's so much emotion attached to this. So I think that's it's a confidence issue for us as well.
And it works at all levels too. For example, gets into complex arrhythmias. You know, as soon as I start having things like Fleck and I, you know, I start talking to my arrhythmia buddies.
Yeah.
You know, we all need to talk to somebody to sign off, even when we know we're doing the right thing. It's hard to. It's an area where, because it's mostly observational data, sometimes you don't feel the most comfortable because it's, you know, the evidence is sort of softer, right?
Great, thanks a lot. On behalf of the Schulich Heart Center, I really would like to thank you, Sam, for giving us this talk. I think that thanks for sharing the copy for us. I'll send it for sure with the resident and staff, and whoever is interested, perhaps email me that I can send you a copy. But again, like, really appreciate you coming today. I'll see you soon.
Great, thank you. Nice
Thanks
to see
a
you
lot,
all.
everybody,
Take
for
care.
coming. See you next week.
Bye.